Welcome back to the culture of healthcare. Here we'll talk about healthcare processes and decision making. In part one, we explored the classic paradigm of clinical care and the role of stories and data in decision making. In part two, we focused on gathering, structuring, and analyzing patient information, looking at how clinicians make sense of complexity. Now, in this part, we're going to shift our attention to how decisions are made across different levels of healthcare, where clinical reasoning meets organizational systems, professional ethics, and the influence of technology. We'll explore how decisions ripple outward from the clinician's judgment at the bedside to interprofessional collaboration to the policies, technologies, and cultural values that shape care delivery as a whole. So let's dive into part three and see how decision making in healthcare is never just about one choice, but about navigating a web of patients, professionals, processes, and systems. Go ahead and dive into the objectives for healthcare processes and decision making in this presentation that are related to this and not the other presentations. So we're looking at the last four on this slide. And the first one is explain the difference among observations, findings, syndromes, and diseases. So, clinical engineers need to understand how clinicians move from raw data to diagnosis. Observations are the raw details like blood pressure readings or lab values. Findings are the clinical significant observations selected by the clinician. Syndromes are clusters of findings that occur together but may have multiple possible causes. Diseases are specific conditions with known causes. By appreciating these distinctions, my accent, clinical engineers can design, calibrate, and maintain devices that provide accurate observations while supporting clinicians in transforming those into meaningful findings. It also helps engineers recognize the consequences of equipment errors. For example, how a faulty blood pressure monitor could derail the entire chain of diagnostic reasoning. The next objective on the list is describe techniques or approaches used by clinicians to reach a diagnosis. So, clinicians often use iterative, hypothesis driven reasoning. They gather data, form possible explanations, test those hypotheses, and refine their conclusions. Clinical engineers who understand this process can better align technology with workflows. For instance, decision support systems, imaging tools, or monitoring devices should deliver data in a way that fits how clinicians test and confirm diagnoses. The next is list the major factors that clinicians consider when devising a management plan. So, beyond the diagnosis itself, clinicians weigh many factors: the patient's age, comorbidities, risks, preferences, available resources, and quality of life considerations. For clinical engineers, this means recognizing that devices and technologies don't operate in isolation. They are part of a care plan shaped by multiple variables. A technology that is too complex, costly, or poorly integrated can limit a clinician's ability to create effective management plans. And the last one for this particular session that we'll cover today is describe the role of EHRs and technology in the clinical decision making process. Electronic health records, or EHRs, and integrated devices provide the infrastructure that links observations, findings, and treatment decisions across the continuum of care. Clinical engineers ensure these systems are safe, reliable, interoperable, and user friendly. If the data flow between devices and the EHR is compromised, or if the system design is unintuitive, clinicians may miss critical information, leading to errors in decision making. In summary, for clinical engineers studying these aspects of diagnostic reasoning and decision making, ensures that technologies they manage don't just work mechanically, but actually enhance clinical care, reduce errors, and support patient safety. Let's dive into diagnostic thinking. Let's think like a clinician for a moment. We're given a set of findings: weight gain and edema, exertional dyspnea, but clear lungs, pallor, high blood pressure, and history of hypertension, tachycardia, and S4 gallop, risk factors for coronary artery disease, and a history of smoking. Each of these is a clue, but none of them alone gives the full answer. Let's start with edema. Swelling could point to the heart, the liver, the kidneys, or even nutritional problems. Next, consider dyspnea, shortness of breath. The heart is one possible culprit, but so are the lungs, anemia, or even physical deconditioning. Tachycardia adds another layer. It could be compensatory, an attempt to keep up with the body's demands, or it might signal an underlying cardiac issue. Now combine these clues: an S4 gallop, long-standing hypertension, risk factors for CAD, and fluid retention. Taken together, these point strongly toward the heart as the central problem, though we'd need tests to confirm. But the key insight here is diagnostic thinking is pattern recognition. It's about weighing each piece of data, considering possible systems involved, and then pulling them together in a working hypothesis. I want to jump into techniques for diagnosis. Clinicians use a variety of approaches to move from raw patient data to a working diagnosis. Each of these techniques reflects a different way of organizing information, testing hypotheses, and making decisions under uncertainty. Heuristics, simple mental shortcuts. For example, when you hear hoofbeats, you think horses, right? Not zebras. Clinicians start off with the most common causes before considering rare ones. For engineers, this illustrates why devices must provide reliable baseline data so the common conditions are not mistaken for technical errors. Mathematics. Tools like Bayes' theorem help weigh probabilities. How likely a disease is given a specific test result. This shows the importance of accurate device sensitivity and specificity, since false positives or negatives distort probability and calculations. Temporal patterns. Timing matters. Accurate, subacute, or chronic presentations point to different causes. Monitoring technologies and longitudinal data capture in devices, EHRs, example, are essential to detect these changes. Systematic approaches. Structural checklists like Vindicate, vascular, infectious, neoplastic, etc., help clinicians view all possible systems. Engineers should understand that structured workflows often depend on technology prompts, so device interfaces should support completeness, not shortcuts. Anatomic reasoning. Diagnosing based on location in the body, such as chest anatomy, imaging systems, and anatomic models are critical tools that engineers support. Then we have pathophysiological reasoning, linking systems to underlying biological processes, for example, bilirubin or metabolism. Lab equipment, analyzers, and clinical chemistry devices must be well calibrated to make this reasoning possible. And of course, pattern recognition, naturalistic decision making. Clinicians match new cases to familiar patterns. Devices that display clear trends, such as ECG waveforms, directly feed into this recognition process. We also have mnemonics, memory aids like P.T. Barnum loves kids. That helps clinicians recall diagnostic steps. While simple, this shows that the human element of memory and recall works in tandem with structured data systems. Let's continue with looking at systematic approach to expanding the differential. So when clinicians face a complex case, one of the biggest risks is anchoring too quickly on a single diagnosis. To prevent that, they use systematic approaches to make sure nothing important is overlooked. One common tool, as mentioned before, is the Vindicate mnemonic, which reminds clinicians to think broadly across different categories of disease processes. So Vindicate stands for vascular, infectious, neoplastic, drugs, inflammatory or idiopathic, congenital, autoimmune, trauma, and endocrine or metabolic. By running through each of these categories, clinicians can brainstorm possible explanations, even those that aren't immediately obvious. Another way is to think through organ systems, for example, neurologic, cardiovascular, pulmonary, renal, hematologic, gastrointestinal, bones and joints, skin. This ensures that symptoms are not dismissed too early and that diagnostic reasoning stays comprehensive. For clinical engineers, understanding these methods is valuable. Technology, from imaging to lab equipment to EHR prompts, often plays a key role in ruling in or ruling out conditions across these categories. When devices are reliable and integrated, they support clinicians in systematically expanding and then narrowing the differential diagnosis. Let's go ahead and take a look at pathophysiologic approach to jaundice. Right? So let's take a look at jaundice. Yellowing of the skin and eyes as an example of how clinicians use a pathophysiological approach to diagnosis. Instead of jumping straight to one cause, clinicians map out the physiology of bilirubin metabolism and ask, where in this process could things be going wrong? There are three broad categories: erythrocyte problems, so if red blood cells are being destroyed too quickly, such as hemolysis, or if there is a disorder of red blood cell production, which is called erythropoiesis, bilirubin builds up in the system. You can have liver problems. The liver is responsible for bilirubin uptake, conjugation, and secretion. Disorders in any of these steps, whether genetic, toxic, or infectious, can result in jaundice. Biliary obstruction. Even if the liver is functioning normally, bile flow can be blocked. Causes include intrahepatic obstruction, bile duct obstruction, or pancreatic cancer compressing the bile duct. The power of this approach is that it keeps diagnostic reasoning organized and comprehensive. Instead of thinking about jaundice as one disease, clinicians consider it as a process that can break down at multiple points. And for clinical engineers, this highlights why technology is so critical. Devices like hematology analyzers, liver function tests, imaging systems, and pathology tools each provide pieces of the puzzle. Accurate, reliable data helps clinicians pinpoint where the bilirubin pathway is failing. Patterns of data in diagnosis. When clinicians approach neurologic problems, they often think in terms of patterns. These patterns help them organize complex information and narrow down possible causes. Topographic patterns. The first question is where the problem is in the nervous system. Is it in the peripheral nerves, the plexus, the spinal cord, or the brain? Clinical engineers can see the connection here. Imaging tools, EMGs, EEGs, and other technologies provide crucial localization data. Temporal patterns. Next, clinicians look at when and how quickly symptoms appear and resolve. Did they develop suddenly, like a stroke, gradually, like a tumor, or do they come and go? The timing reflects the underlying pathophysiologic process, and technologies such as continuous monitoring can capture those changes. And clinical context, the company it keeps. Symptoms rarely occur in isolation. Clinicians interpret them alongside other signs like fever, underlying comorbidities, for example, valvular heart disease, or past history such as smoking. This reinforces the idea that diagnosis is never just about one data point. It's about patterns in a broader context. For clinical engineers, recognizing these diagnostic patterns shows why technology must provide accurate, timely, and contextual data. Devices don't just give numbers, they support the clinician's search for patterns that lead to better decisions and safer patient care. Heuristics in diagnosis. Clinicians often rely on heuristics, rules of thumb that allow for quick decisions in uncertain or time pressured situations. Some common heuristics include err on the side of life. If in doubt, take the safe route to protect the patient. When you hear hoofbeats again, you look for horses, not zebras. In other words, start by considering common conditions before rare ones, unless your context changes, like being at the zoo. Uncommon presentations of common diseases are more likely than rare diseases. For example, pneumonia presenting unusually is still more likely than a truly exotic illness. These shortcuts can be extremely helpful, but they also have weaknesses. They can lead to cognitive errors when a clinician jumps to conclusions too quickly. They may introduce biases, causing rare but critical conditions to be overlooked. On the flip side, heuristics have a major strength. They are fast and frugal. They allow clinicians to act quickly in emergency or resource limited settings where time and information are scarce. For clinical engineers, this highlights why technology design must balance speed with accuracy. Devices that deliver rapid, clear results support fast heuristics, but they must also be reliable enough to prevent misleading data that could reinforce a cognitive error. Mathematical approaches to diagnosis. Sometimes diagnostic reasoning depends less on intuition and more on mathematical frameworks that help clinicians weigh probabilities and risk. Bayes' theorem, sometimes pronounced, well, it's pronounced Bayes' theorem. This principle updates the probability of a disease as new evidence is introduced. Mnemonics like SPIN, SPIN, a highly specific test when positive rules in a disease, and SNOUT, SNOUT, right? A highly sensitive test when negative rules out a disease, excuse me. And this makes it easier to remember. SPIN and SNOUT. Decision rules. Let's talk about these. Clinicians often use structured scoring systems to standardize care. Examples include the Wells criteria for pulmonary embolism and the Centaur criteria for strep throat. These rules reduce variation in practice and give clinicians a more objective way to decide on testing or treatment. Decision analysis. In complex cases, clinicians may use models to compare risk and benefits of different diagnostics or treatment pathways. This can guide high stakes decisions where uncertainty is very high. For clinical engineers, the connection here is subtle but important. Many diagnostic devices, from imaging systems to lab analyzers, feed the numerical data that fuel these decision models. If the technology is inaccurate or poorly calibrated, the math breaks down and patient care suffers. Engineers ensure that these numbers that clinicians rely on are trustworthy, which makes mathematical reasoning a safe foundation for diagnosis. Talk about information system tools in healthcare. So, modern healthcare doesn't run on memory or paper alone, it runs on information systems that connect people, connect processes, and data. Electronic health records, or EHRs as you know them, right? These are the backbone of patient information, keeping track of diagnosis, medications, test results, and treatment plans. They ensure that everyone on the care team is working from the same set of facts. Clinical information systems. These systems handle specialized data like lab results, imaging, or pharmacy orders. They integrate streams of information from different sources, so nothing critical is overlooked. We have clinical support systems. These tools go a step further by offering decision support. They flag dangerous drug interactions, suggesting evidence based treatments, or highlighting abnormal results that need urgent attention. We also have other electronic tools, and these will include things like emails, apps, health information exchanges, personal health records, and medical reference resources. Together, they make care more connected, accessible, and transparent for both the clinicians and the patients. But for clinical engineers, this is where their work intersects directly with patient safety. Engineers help ensure that devices communicate seamlessly with these systems, that the data they send is accurate, and that technology supports, not hinders, the flow of care. Reliable systems mean clinicians can focus on decision making, confident that the information in front of them is both complete and trustworthy. In summary, in this lecture, we explored how clinicians think and the different approaches they use to reach a diagnosis and make decisions. We looked at techniques for diagnosis, systematic approaches like Vindicate to ensure no possibility is overlooked, pathophysiological approaches, which analyze breakdowns in normal processes such as bilirubin metabolism in jaundice. We looked at patterns of data in diagnosis, topographic patterns to localize a problem in the nervous system or the body. We looked at temporal patterns to track how symptoms develop or resolve over time. And we looked at clinical context, which considers comorbidities, associated symptoms, and patient history. The other area that we looked at was heuristics, the rules of thumb that help clinicians make quick decisions, recognizing both their strengths in emergencies and their risks for bias. We also dove into mathematical approaches. We looked at tools like Bayes' theorem, decision rules, and probability models that support evidence based structured decision making. Taken together, these methods remind us that clinical decision making is both an art and a science. It blends pattern recognition, structured reasoning, heuristics, and mathematics, always guided by context, though. And here's where clinical engineering quietly fits in. Every one of these approaches depends on reliable data, accurate devices, and well integrated information systems. Engineers ensure the foundation is solid so clinicians can think clearly, decide confidently, and act safely. Brings us to the end of this lecture on healthcare processes and decision making. We've seen how clinicians combine systematic approaches, pathophysiological reasoning, heuristics, and even mathematics to make sense of complex patient cases. Each technique has strengths, limitations, and context where it shines. Together, they remind us that diagnosis is both structured science and practical art. And for those of us supporting healthcare from the engineering and systems side, the lesson is clear. The tools and data we provide must be accurate, reliable, and well integrated because they feed directly into the decision making process. I want to thank you for your attention and engagement. Keep asking how technology and clinical reasoning can work hand in hand to improve patient safety and outcomes. Remember, every decision in healthcare is a step towards safety, and every role, whether clinical or engineering, helps light the path.